Welcome guests, welcome attendees, good morning, good afternoon, good evening, depending on where you are joining us from the world today and where you might join us in the future through watching our recorded version. Welcome, hope the day is going well. Thank you for joining us for another episode of the DHIT Frequency. This is the Digital Health Institute for Transformations webcast and podcast series. It's where health innovators, problem solvers, and transformers come together to talk about best practices, next practices, and all else in the space of digital health and healthcare transformation. I'm your host, Michael Levy. I'm DHIT's president and moderator for today's panel. I usually am joined, certainly for this season, with my co-host, Kathy Malice, but unfortunately, she was unable to make it today for conflict that just emerged and popped up. So do apologize for the miss there. I do hope that I can bring the same level of energy for this session and skill of and craft of facilitation that Kathy brings. I'm excited about our panel today. I'm excited about our panelists. Taking a look at the rear for the moment, the last two episodes we hosted over the last month, bringing together some incredible thought leaders and subject matter experts to talk about the space of mental health and aging in place. Very important subject matters similar to pediatric care. What we heard in the general theme coming out of these two episodes was really, an incredible amount of challenges and said otherwise opportunities that still exist in our system across these areas. From a mental health perspective, we're seeing an incredible rise in general anxiety and stress disorders, as well as increased rate of suicide. Obviously, COVID doesn't help the situation. From an aging and aging in place perspective, we carry over some mental health narrative, but we also have some real operational and challenges with caregivers and our aging population from a volume perspective, let alone the complexities of how we orient care for aging. And now we're going to be talking about pediatric, the other end of the spectrum. But I can only imagine that the challenges and opportunities are still there and in existence with our pediatric population. What was refreshing, however, and I'm hoping that this conversation kind of outputs similarly, was the optimism and the outlook that our panelists shared about our cultural transformation that's going on right now from a digital, from an adoption perspective, the natural opportunities and potentials that emerging technologies and health tech technologies have to support in this very real situation that we're dealing with in respects to our health outcomes and comorbidities and health inequities across the U.S. and Canada. So I expect that we're both gonna hear some similar themes of challenges, but also take away and move forward, hopefully with a level of optimism that and excitement perhaps of what the future might hold for us in pediatric care. So I'm naturally looking to tie these episodes together with a common theme, and it seems like this is prevailing. But before we jump in, I want to take a moment to thank our incredible partners and acknowledge their investment into this season of DHIT Frequency and to our relationship at DHIT.
Thank you to the Government of Quebec and the Hospital Center of University of Montreal. As the coolest hotspot for innovation, we're proud to have the Government of Quebec as a disruptive partner.
Indeed. Well, without further ado, let me introduce our incredible panel that will help us navigate this discussion and conversation today. I'll start with a friend and colleague, Dr. Jennifer McCafferty. We've known each other for many years, started a relationship connection at the University of Miami back in 2012, I believe. Or before. Jennifer, it's amazing to have you on here today. You're the Chief of Staff, Chief Research Officer for Nicklaus Children's Health System in Miami. and outside of being a friend and colleague, just an amazing and dynamic person. It's great to have you here, Jennifer. We have Dr. Philippe Jouvet, a pediatric intensivist, a clinical professor for Sainte-Justine University Hospital Center in Montreal, as well as the scientific director of the Health Technology Assessment Unit as part of the innovation platform for Sainte-Justine Hospital. Thank you for joining us, Philippe.
Thank you.
And we have Marc-Antoine Pelletier, managing partner for HOP Technologies, a startup company working on the development of a technology suite incorporating deep learning algorithms to help patients, parents, and teachers, therapists contribute to the development of children with autism spectrum disorder or any other intellectual disabilities. Thank you, Marc, for joining us today.
Pleasure.
And one last note before we get going, audience, please feel free to send over questions through the Q&A function of Zoom. I'll be caring for those throughout and interweaving them as we continue down this discussion, and perhaps we'll have some time at the end for any comment at the end and point them directly to our panelists. But panelists, let's go. Jennifer, let's start with you, if you will. As Chief of Staff at Nicklaus Children's Health System, can you kind of elaborate, give us an idea of the conversations and the importance that Nicklaus Children's is placing on digital transformation? You know, what are the conversations like, and perhaps can you give us an example of a program that you've launched or that you're thinking about launching in the future to support the organizational strategy?
Yeah. So first, let me thanking you, Michael, for inviting me to the panel, and to my co-panelists. I know there could not be a more appropriate time for us to continue to push down the pathway of digitization of how we think about healthcare. I would argue particularly in the pediatric space. So as Chief of Staff, part of my portfolio not only includes kind of our innovation engine, but I'm also responsible for strategy at the system level. And really for us, the commitment to digitization started several years ago. You know, everybody implemented their EMR at different times. For us, we were I would say, an early adopter of telehealth, and really thinking about kind of patient-facing and provider-facing mobile health applications. But we didn't go all the way in telehealth, and we didn't really have the opportunity to go all the way in telehealth, largely to the last 6 months. And so I think we can come back to that when we start talking about the impact of COVID. But for us, from a strategic perspective, digitization has been one of the pillars of our organization since the mid-2000s. And really, where we've looked at specifically is a few different areas. The first one, in 2018, we opened an advanced care pavilion, which was a six-story subspecialty tower where we essentially realigned all of our surgical services and our intensive care units into a single completely modernized tower. And the digitization piece went beyond just thinking about how we shared health information among providers as well as the patients. We actually went all in with things like location intelligence, wayfinding, other different types of tools that would allow us to enhance the provider experience, the efficiency of healthcare provision, and also what the patients were experiencing within that tower. You know, we've gone through some pretty significant leadership transitions in the past 2 years within the organization, and where we've kind of moved now, you know, we continue to focus on digitization from sort of a traditional sense in terms of healthcare information. But as we move forward and rolling out our new strategic plan, which is slated to begin in 2021, we are unequivocally putting patients and families first, and really trying to understand different digital platforms and how we can manage digital health, but squarely focused on the patient and the family and what their experience is, particularly for our chronic complex patients in navigating pediatric healthcare.
Yeah, that's you know, it's a winding road, and it seems like it's a very broad space to travel when you're thinking about optimizing the experience of patient and family, but starting from a tower and looking at it through the lens of a hospital system and the four walls of a hospital to, treating and managing and caring for the life of these patients and families at the edge, at their home and their community. I would imagine, the conversations at a strategic level are how best do you provide that level of service and care, extending it out into the community? Is that a focal point as well?
It is. I think, our primary emphasis are on the patients and families that we're providing care for. So specific examples of things that we're exploring in our planning implementation on are things like, well-being companions, digital care assistants, that kind of concept. And then as we expand into more of a preventive health, population health perspective, that's where we're more focused on really how can we provide the most up-to-date, most accurate, and critically most fun and actionable health information that can provide preventive care information for those kiddos that frankly we never want to see in the hospital, right? Our job is to keep kids out of the hospital, not to bring them in, and really understanding creatively how we marry those two pieces is kind of the sweet spot that we'd like to get into. Make it as memorable in a positive way that we can when they're in the hospital, but really continue to grow the identity as a freestanding pediatric hospital as the go-to source and trusted partner for actionable information about and practical information about health and wellness for kids.
I love it. Philippe, let's take down now from system down to practicing clinical innovator, practicing physician. You're running a technology health assessment unit within the innovation platform of Sainte-Justine. So I'm imagining in your role, you've really been hands-on evaluating emerging technologies and healthcare applications as it relates to really driving some of the experience and clinical equation that Jennifer was just speaking to. Can you speak to what your experience is within that unit, and then perhaps pinpoint maybe an example or two of innovations that you've seen really drive impact?
Yeah, so first, thank you to have focused this session on child health, because it's really an important one, even if they are usually healthy. When there is any disease and they need to be admitted in hospital, then it's a big challenge. Taking care of innovation, the first question I had is what is the innovation we have in intensive care unit that has changed our practice? I'm working since 1985, and since this period of time, the main one that has changed my practice is pulse oximeter, because before pulse oximeter appeared in intensive care, it measures the oxygenation of the blood, and now we can have it in any shops easily. But before that, we were just looking at the child and seeing if the child was blue or not. And when you are blue, usually it's really late in the hypoxemia process. And with the oximeter, we were starting to monitor the patients as soon as there was something wrong. And we adapted this treatment. And with time, we increased the monitoring around the child. It was also the case in adults. And nowadays, we have a large monitoring system around the patient. And there is at least 200 parameters that are coming every second from our monitoring system in intensive care unit that we have to cope with and manage the patient. Of course, there is the history that makes that these variables are connecting one to the others, and so the interpretation is making easier with time when we look at the child. But there is a lot of data around, and among the innovation that we developed at Sainte-Justine Hospital, and it's also the case in other hospitals, is to capture all this data, to stop the data hemorrhage, and to be able to create systems that analyze this data in real time to help caregivers, not only doctors, but also nurses, respiratory therapists, and other professionals in the ICU to manage the children. And so we developed such an infrastructure, and now it's an infrastructure that is used for innovations. And what we created recently, and I think it's a field that is growing, is also to include all the imagings of the behavior of a child. So that means using cameras to have access to the visual aspect of a child, and then interpret consciousness, respiratory distress, hemodynamic distress using even thermography, and also analyzing the movements to see what is the neurological condition. So all these innovations are now on a research perspective, but will come progressively into clinical practice to help the management of the children. That's the main things we do, and the idea is now to spread this kind of innovations on development into the whole hospital. It's not surprising that it starts in ICUs. It's because it's the highest technology environment in an hospital. But nowadays we are working on some monitoring systems that are wearable, and then that can detect any vital distress outside the ICU. We are also thinking to implement such systems into the medical transport systems, either with a plane, an helicopter, or mobile transportation.
Yeah, that's a great framework, really, that you kind of laid out there from an innovation platform perspective, focused on the technologies that you leverage to evaluate and collect vital data, to the information processing that's critical to turn that data into insights, and then the extension of the appropriate care and engagement, turning that insight into action, and starting within an environment which has a high adoption rate, let's say, to emerging technologies, and getting it right, and then spreading across your system. Is that a fair summary?
Yes, it is, and there is a lot of challenges there. First of all, is we need to collect the data and not to lose them. So it's you have to create an environment that can collect the data, and after that, you need to have valid data. So there is a lot of artifacts when you capture data. So you need to develop some algorithm, and it usually use deep learning methods to remove the artifacts. And after that, you have to implement medical knowledge. We always think that we will create a new knowledge, but I'm quite, at the moment, we work on our actual knowledge and try to put it into softwares that can help caregivers. And after that, you need to implement that into the workflow. So it needs to come when you need it, you see. So so how are you organized to be able to be advertised of anything at the proper moment when you are taking care of a child? There is a lot of challenges, and we need to solve all these problems.
It is like I say this over and over again, in various settings, but to me, I always look at our date and time in this world as it's 1920 in the 21st century. When we're looking at digital transformation, you can map back 100 years and see the transportation transformation that was happening, but we were still trying to make horses faster. I feel like we're in a lot of respects in that period of time where we're learning and figuring out what foundations do we need to build to actually drive innovation, and what does that look like from an investment, operations, culture perspective, outside of just the possibility of transformation by way of the technology itself. Marc, let's jump to you as a leader of a technology initiative focus. I shouldn't say a technology initiative. You're solving an incredible or supporting an incredible problem, which is to care for children and families with autism. Can you explain maybe your mission of HOP Technologies, and then tying to some of Philippe and Jennifer's statements around the kind of experience today integrating inside of workflow systems that are already existing. How do you advance the potential of your solution to actually drive impact in those that are intended for this solution to serve?
Yes, absolutely, Michael. Just a technical thing. I'm actually on my iPhone to get the signal. I'm close to the Vermont border right now, so no Wi-Fi. So in case you lose my voice, I'm going to shut my camera. But thank you again for hosting us this morning, Michael, Brian. Thanks to the co-panelists. Thanks to you all this morning. Before talking about the mission of the company and why we did that, I mean, the reason really was to relates to the biggest challenge with respect to autism spectrum disorder. Today, there are no real drugs that are available. There's no one-size-fits-all therapeutic solution for autism spectrum disorder. So, and also parallel to that, the biggest challenge for autism is that there's no one alike. There's a well-known saying that you know one autistic individual well, so you only know one. And the reason why HubChild was started in 2013 at the inception was that because my two partners, who are pediatric occupational therapists, and we kind of questioned, should I be there or should they be there? But I think we decided to go digital. And they basically explained to me then that they were basing their therapeutic intervention based on empirical approaches. So basically approaches based on experience and observations. And one of their biggest challenge was, relating to also the parents. A lot of parents went to them and said, over and over, what if we could know what is going on inside our kid or our children, and these then parents could provide, so that these parents could provide better healthcare, better caregiving for their kids. So as an engineer, as an entrepreneur, I basically started looking at what was there in terms of potential solutions, and realized very quickly that the way the clinical trials were done, the way the research was done, I really realized quickly that there was a gap in terms of getting the right information, which is non-biased data, biased and experienced clinical observations. And, at this stage, after 7 years, basically, our mission right now, to answer your question, is really to provide a smarter toolbox to the healthcare professional, and also to the research people also on the ground that are trying to look at improvements of methods and techniques and therapeutic interventions. So to make a long story short, we've built this, an end-to-end platform, and it's called Health Optimizing Platform. That's what the HOP acronym comes from. And I'll explain that later. You gave me a few minutes at the end. I'll try to explain that a bit more. So that platform is built to gather non-biased data and personal labels. When you're talking about machine learning, artificial intelligence, labels are key. Label data are key, whether they're objective or subjective. So really, this was to better understand the person from within. So that's how the whole story of HubChild started, from its inception to actually today. So right now I'll explain a bit later where we're standing with that solution. But basically, what we propose to the market right now is to build algorithms that are custom made for their particular needs. So any researcher or company could come to us and say, look, I've got a particular need in one particular area of healthcare using digital equipment. I would like to have my particular and my custom-made or tailor-made algorithm. And because we have that large machine learning and data analytics and data science team, we're able to provide that.
So, I mean, autism is where you're focused, but the platform itself is extensible to other problems, presumably.
Yes. Very shortly, to answer your question, the solution basically extend towards autism, or let's say outward autism, and because we've developed that particular platform which has a lot of flexibility, we're basically able, as I mentioned to you, able to customize it to other clinical needs. So what happened is March 13th, we were actually having a project with the Bureau of Innovation at the Ministry of Health in Quebec, an autism project. And, we just got discussion with them, and they basically asked us if we could adapt our platform for a COVID-19 project. So this is really where, we're, and I'll explain that a little bit later. We ended up right now using that particular platform for COVID-19 investigational testing in 2 different Quebec hospitals, McGill University Health Research Institute and the Cardiology Institute of Quebec City. So what we developed for autism, especially for cognitive impairment, is extremely useful for the COVID project we do execute right now.
Got it. We're going to come back to that here in a second, because I want to, naturally we weren't going to last long without, COVID popping up and it's being so relevant and particularly a big question mark around, COVID and children. I wanted to tug on Philippe for a moment here and get your perspective, because my understanding is that we don't really have a direct understanding itself of why children are less affected by COVID and what the relationship between COVID and pediatric individuals are. And so I'd love to hear your perspective and your theory, I guess, at this point of what's going on there. What are your thoughts?
Well, I don't want to give fake scientific information, so I will speak what I feel, but there is a lot of research that is ongoing, and some are going on this way. First of all, it's a rare disease where children are not ill. You usually, when you speak of infection disease, the 2 populations that are really damaged, really ill, are children and elderly. And at the moment, it's very strange to see that children are not ill, and that's good, of course. And the question why? First of all, this helps to realize that a child is not a small adult. You see, if it was a small adult, then they should be as ill as adults, but it's not the case. So there is something that comes with age, and that helps COVID virus to be more aggressive. And one point, there is a lot of immunologists that are working on that, and it's the inflammation reaction to any infection. And my feeling is that this kind of reaction to inflammation is deteriorating with age. And children are able. Inflammation is like a fire. You see, you have an aggression, and then you react to cool it down. And this aggression creates a fire that is all the immune system that tries to move it out. And if you are able to cool it down very fast, then you are not ill. And if you are not, then you are severely ill. And probably with time, we have more and more difficulties to cool it down. But that's a simplification of the field, the way we think to it. But of course, it needs to go into details. So what are the triggers of that, and how we can support or decrease such things? And one example is that if a patient is really ill, when we use steroids that are anti-inflammation, and it seems to work. And when you use in ICU, when you use steroids on children or even adults that have got a severe respiratory disease usually doesn't really work. It facilitates another infection, and then the patient is getting worse. So that's a rough idea, but I'm well.
I like that.
I mean,
I guess it's safe enough to take anti-inflammation supplements, right? Should we? would that be beneficial for us all? Joking aside, Jennifer, using the analogy of hot and cold, I guess system. Looking at the system as described by Philippe and children. Look at it. Let's look at it from the system perspective of a health system. What if any stress or impact or variability did Nicklaus Children's go through or is still going through as it relates to COVID, considering the lesser of, let's say, impact to pediatric patients? Naturally, I think of your staff and employees, but what give us a sense of the last 6 to 8 months in your world.
I would say, yeah, I mean, hectic, right? We continue to, I think Philippe said it very nicely. We continue as a pediatric hospital and as pediatric care providers to live almost in this dual reality. Meaning we are, as he so eloquently articulated, we know that children are at lower risk for sort of severe clinical presentation as it relates to a COVID-19 diagnosis. The jury's still out on how children spread it, on asymptomatic spreaders, and on all of those pieces. Having said that, we, Nicklaus Children's is in Miami, Florida. So we were a hotspot, really an epicenter for several months out of the United States. Which is saying something given where the US is relative to other countries in the world. So for us, we had this sort of, again, dual reality of being thankful that we weren't seeing an influx of pediatric patients into our facilities. The patients that we were seeing who were getting quite ill tended to have underlying comorbidities, which would be consistent with Philippe's articulation, again, that the ability of the immune system and sort of having other things going on that would kind of run into anti-inflammatory, inflammatory processes appears to be a consistent pattern that we and others have seen and have reported on. So we were thankful for that. And from a clinical perspective, we were one of the first hospitals, pediatric hospitals in the US to create a subunit within our pediatric intensive care unit that just focused on the multi-system inflammatory syndrome that we see kind of as a sequelae for pediatric patients. So that was dedicated space, cohorted off with negative, a whole bunch of different pieces that were put into place fairly quickly. So there were some logistic things that what we did were common really to what you would see in adult facilities in terms of cohorting. The other part of that reality though was the fact that all of the folks who are caring for these kids are adults.
Right.
And everyone who's coming in, the children are not showing up alone, obviously, thankfully. Right. Mom, dad, and in our region, we tend to have multi-generational families which all come together when a child is ill into the emergency room or into the urgent care or into the pediatrician's office. So we were also dealing with a scenario where we had at-risk populations, meaning folks in their 60s or older who were really wanting to be part of the care environment. So lots of things moving in those parts. So what we did, again, similar to what many children's hospitals around the US, I'm sure in Canada as well, we started to do things like limit visitors. We had massive amounts of PPE, personal protective equipment that was made available. We cohorted patients. We had kind of a pivot to our triage facilities as patients were coming in for testing and whatnot. And a lot of it was stress management with our frontline workers, right? With our frontline care providers, and really trying to understand how we were as supportive as we could be during a time when not everybody had all the answers. Remember, back in March, April, May, there was a lot of uncertainty that everyone was dealing with. So one other thing that we did I think, which was really important and also has implications for the long-term in pediatric healthcare environment within our region, was we were fortunate enough to come together as a region. So this meant all of the health systems that generally compete with one another, all the CEOs got together and said, we need to come up with a regional solution. How can we work together and collaborate? Because remember, again, there was a time back in sort of May where we were projecting surges of patients that would have been similar to what our colleagues in New York City saw. Right. And so there was a massive effort really to understand, how do we begin really working together to determine where would COVID patients go? Where are they best served? How can we do this collectively and together? So one of the things that we that came out of this and now has been formalized, one of our local health systems had limited pediatric, and they had a dedicated pediatric inpatient unit. But during COVID, they decided to enter a transfer agreement with us. So all of their inpatient transfers came to Nicklaus. If a patient presented in the emergency department and they required inpatient admission, that our transport team went, picked them up, and they were admitted at our hospital. And that was very deliberate and very intentional, because the idea was the adult patients need to be cared for in the adult setting, and the pediatric patients need to be cared for in the pediatric setting. So how do we make this work? And the partnership turned out to be so successful that we, again, as our COVID numbers and our likelihood of a surge has minimized, we're continuing with that work. So it's really also allowed us to think more broadly, not just in the context of COVID, but also when we think about quality outcomes for our region. How do we work together and sharing? And there was, data sharing, all of these things were inherent in these partnerships. How do we work together to focus on the quality outcome at the end that we're really striving to achieve? So for us, there definitely were challenges and continue to have challenges in COVID. But we have seen some glimmers of positivity, if you will, around what we can learn, particularly as it relates to being nimble and being resilient, and keeping our focus on why we do what we do, which is really our mission to take care of kids who need us.
Yeah, thanks for that great context and walk through your shoes, so to speak, point of view. Certainly can imagine the stress of a system like that, having to flex and learn on the fly. But as I hope, there's this tunnel out to optimism that we're headed towards, because that collaboration, that ecosystem, regional system that you spoke about, kind of coming together in the fire and that heat. Again, it almost mirrors what our pediatric patients are doing in COVID, where a healthy immune system's attacking, and it seems like a viable framework for handling chronic disease and other such ailments, not just the pandemic. Do you see this type of behavior increasing?
I do, and I think what's been great about it, it was an opportunity to kind of go down a proof of principle way of thinking, in a way that the stakes were high enough that hurdles that had presented themselves in the past to these types of collaboration had been removed. And so for us, we have an extraordinarily forward-thinking CEO in Matt Love, and he has been a driving force for that type of applied innovation, and really, thinking about how we do better, and how we can innovate, not just at the individual patient level and at the bedside, but also how can we innovate in the context of care delivery. And those are pieces that, again, when we think about from our perspective, sort of strategically where we're trying to place digitization and kind of innovative thinking, it really kind of goes up and down that microscope, if you will, from the macro to the micro. Yeah,
that's that's spot on. Marc, from an entrepreneur's perspective, are you seeing and feeling the market align a little bit more now from the perspective of take the Nicklaus Children's and the regional, kind of collaboration of Miami, et cetera, and saying, how do we take advantage of all of what we can, from emerging technologies to shared resources to data? Are you seeing the same type of alignment and adoption and or use of technologies from your vantage point?
That's a very good question, and I'll basically start my my point with a personal point of view. Basically, United States is probably more organized than Canada, believe it or not, with respect to taking care of autism spectrum disorder, especially in the education sector and the insurance coverage. So we often, Canada's often seen as an example for Medicare, but unfortunately, United States is probably well more organized than Canada at this stage. As far as COVID is concerned, there's been some tendency that were observed, and I'll cite two here. It's really relating to children that did not have to go to school. It's amazing, but on March 15 everywhere here, or let's say March 20th, the children had to stay home. So this actually created, at one hand, a certain level of security because they were staying home and they were not confronted of being, going to school and having to have agitation or anxiety related to this kind of social event for them. So comfort on one hand. On the other hand, some became increasingly agitated. And you know about autism, they can have meltdowns, and because their routine is actually changed, and it's no longer what it used to be. So who's basically taking the load? And I agree so much with Jennifer here. The parents. So basically, the caregivers are very much solicited, and they actually end up being collateral. They actually act as a buffer, basically. So it depends on the culture, it depends on the country. But if you go North America, and I'll make a long story short here. Autism has been there for a long time, and it's going to be there for a long time. That pandemic, has changed some things, but at this stage, going remote patient monitoring, remote intervention is something that's going to happen more and more with that kind of population.
Yeah, that's fair and interesting as it relates to the difference in Canada versus the U.S. as it relates to the maturity of caring for those with autism or supporting those with autism. Philippe, speaking about remote, you mentioned it at the first part of our session, talking about I think you mentioned autonomous vehicles or bringing the ICUs, so to speak, to a location. Do you see in the future remote kind of care, step down care from the what level of care is going to be in our house, and when? Can you foresee this?
Yes. Well, there was a vision that in the future there will be management of a patient at home or in ICUs. You see, and not a lot of care in hospitalization. It can be day hospitalization, day admission, but you go back home and then you are monitored in brackets lightly at home, and if you are really ill, then you are in ICUs. That was a vision that was 10 years ago, and it didn't move so fast there, but we increased our day hospital care, but not decrease so much the current hospitalization wards outside ICUs. But we are increasing the way we can monitor patients at home, either intermittently or even continuously. I've spoken about this wearable device, and this can be connected to caregivers that can look after the child at distance. So we are moving there. I'm working with a company at the moment for wearable device for children, Vital Tracer, just to name it. I don't know if I can, but and I think the device would be available next year. After that, we need to incorporate that into the process, the care process, and this takes time. Usually, it's a few years. There is another company that combine information from the electronic medical record on this wearable device to look after the child and trigger an intervention if there is something that is outside the thresholds that you have already designed. So we are on this process, and I think this will increase. This will decrease the number of children that are in an hospital for a long period of time, except of course the ones that are in ICUs. That's the vision and where we are going. And there is a willing about parents not to come to hospital for just a control, you see, and stay 2-3 days without a lot of things that are done at that moment.
So in other words, it's less about bringing the ICU to the home and more about preventing the patients to come to the ICU.
Well, when ICU creates its own prophylaxis, you see that's what I mean. And when you look at the evolution of the admission in ICUs, we have really changed the kind of patients that are admitted. When I told you that I started in the 1980s, and there most of the patients had diarrhea and some had respiratory failure. Nowadays, it's rather a lot of children with comorbidities and complex disease, unless these patients with diarrhea are not going in ICU anymore. You see, it's the same for trauma. We have decreased a lot of the trauma. We have decreased the intoxication. The kind of infection that are admitting is also decreased with vaccination and the care that we provide before. So we have changed the categories of patients that are admitted in our ICUs, and this will carry on with the future. So ICUs try on medicine at large care tries to decrease the number of patients that are admitted. But
I love that. We're at that point in the episode where we ask a few rapid fire questions, kind of break it up a little bit. Ask each of you in sequence, 1, then 2, then 3. And we'll keep it short and sweet, and to elicit reaction and some imagination. Jennifer, I'm going to start with you. What do you know? This is the first question. Give us one stat or one thing that you know that we might not know, or that you want to make sure that we know about.
So I apologize. This is more specific to the U.S. than Canada, but it's a statistic that continues to blow my mind and keep me up at night to some extent. And that is that today in 2020, there are more beneficiaries of the Medicaid program than Medicare in the United States. So to give context, Medicare is the government-funded healthcare support that largely focuses on our seniors. So you become eligible for Medicare as you hit your mid-60s in the US. Medicaid is considered the safety net protection. And historically, Medicaid has largely been for disabled or children with chronic complex diseases that didn't have access to care elsewhere. So the fact that we have more people today in the United States receiving Medicaid benefits than Medicare is mind-blowing to me, because the US healthcare system continues to focus on Medicare as opposed to understanding the totality of the need for high quality healthcare across all age groups and all demographics.
Yeah, that's certainly hard to digest, and perhaps might explain the next question I'll ask after I conclude here with Marc and Philippe. Mark, same question. What's in your head that should be known across all of ours?
Well, I'm just going to throw one number. It's $400 billion, and that's what's going to be the cost of autism spectrum disorder in the United States in 2025. So
you say 400 billion?
400 billion, $500 billion.
My
So
goodness.
this number is quite important. And, you know, I can say just one thing: if we can have those autistic people become more, have a better contribution to our society, and we do involve and we do employ some autistic scientists and researchers in our team, that would bring that cost down. So basically, we're doing all our best in order to reach the 2040 target that you've been looking at earlier on in some of your questions. So the kids of today are the adults of tomorrow, and we're taking care of them to make them become.
Yeah, and I think that's poignant when we talk about the Medicaid, Medicare reality, because they'll eventually become perhaps in the Medicaid bucket down the road. But Philippe, what about you? What should we walk away ensuring we know?
Well, what is in my head is medical knowledge, you see. I've worked many years on that. And what I would like is to put it into systems that can help continuously across 24 hours a day and 70 days a week. And that's really where we have to go. So it's the idea to incorporate medical knowledge into support systems. But otherwise, we always need to carry on clinical research to improve our care and knowledge, and that never stops. You see, there is always something else to discover.
Naturally. And this, thank you, Phil. This next question, it's eliciting a reaction from you. One word, 2 word, 3 words at most. But and it's interesting because it actually flips from your point, Mark, about those with autism. This is about those with cystic fibrosis. And the stat is do the access issues within the U.S. patients with cystic fibrosis, and I would imagine that Jennifer's point here about Medicaid is probably relevant here. This condition, affects all children's hospitals, so they're very familiar with it. But ultimately, those in Canada that have cystic fibrosis are living 10 years longer than those in America with the same disease and roughly the same knowledge set and treatment options, et cetera. What's your reaction to that, Philippe?
Well, the management of cystic fibrosis did not change a lot for the last decades, and so it's rather how we look after the child day after day, and the management around him or her. I think in the future with the gene therapy, because it's a defect that is a genetic defect that triggers a specific point on the cells. Then if we could treat that, and we did not discover the way to treat it already, but that's really the big challenge, and that's where we should go. I can't speak more about differences in genes than the management needs to be the best at
better. And I think that's the point that they're making on the access issues, is that it's a disease with such significant management narrative that the difference in Canadian resources versus American resources at hand to every patient with cystic fibrosis is what is unlevel and imbalanced. Jennifer, any reaction?
Yeah, I mean, in a word, I would say unacceptable. Yeah. There are multiple challenges, and I think, to Philippe's point, there are some newer medications that are available that do target some of the genetic underpinnings for CF, but they're incredibly expensive. And how people have access to them and how the coverage for those medications occur will continue to be challenging. And we're seeing this even in thankfully a rarer disease in spinal muscle atrophy, or SMA, where there's recently been a medication approved for that, but again, which is exorbitant in its cost, but life-saving in its outcome. I mean, the other piece I would put into that is on the CF story, the other challenge, and I think this is where the US can take a lesson from Canada, is really trying to understand, how does care transition occur? So once a child moves into adulthood, you know, who's really driving the management of that cystic fibrosis patient as that child becomes an adult? Because thankfully we're seeing CF patients live into their 20s, 30s and beyond, and even becoming parents.
Right.
And how we manage that care transition and assure that we're continuing to focus on what that patient needs as they move out of the pediatric setting, I think in the US system is challenging, because chronic complex disease care transition continues to be a challenge for our system.
Yeah, that's insightful, Mark. In interest of time, what I'm going to ask us to do is maybe piggyback this reaction to your case, your use case you'll share with us, and a little bit more about HOP as we wind this panel down. Just give your reaction to a stat, but then maybe just share in the last few minutes a little bit more about HOP technologies and what y'all are most proud of. Yeah,
Michael,
Yeah.
before you, can I, sorry to interrupt, Mark, just one thing that we haven't said explicitly, that I'm not sure if Mark's going to cover it or not, but I think it's particularly for this venue, it's critically important for us to sort of digest, is this notion of digital equity. So whereas we focused on access and kind of availability of providers and things like that, and insurance coverage historically, as we move into digitized healthcare, understanding this new chasm that will be created between individuals who have access to smartphones and other pieces on a regular basis, that becomes our new challenge in disparities. And I think that's a hugely important piece, particularly in the pediatric space, because kids don't decide if mom or dad have a smartphone.
That's a great point. Thank you for adding that, Jennifer. Appreciate it. Mark, will you just give us a couple-minute overview of your world for a moment?
Yeah, thank you very much. Well, actually, I'll try to be short, but explain, what was the roadmap of our health optimizing platform. So basically, I mentioned that earlier on. We've been working for about 4 years to build a proprietary wearable. So that includes very innovative sensors specific to autism. And we do have also with that platform a numerical labeling system, and we did build a personalized avatar, which actually is the interface, a friendly user interface to support the intervention. So if I come back on our wearable, amazingly, some of the sensors that we developed for autism, namely one which is related to stress and anxiety, will be used later on in the COVID-19 investigational testing that we're executing right now. So our wearable contains, I would say, a very large amount of sensors for both vital signs, but also for the environment in which the person actually evolve on a daily basis. So the endpoint that was done through those years was, basically come up with a clinical discovery platform, both for digital and for pharmas. And that endpoint ended up to be also remote patient monitoring. So we were there 4 years ago. Digital therapeutics for us is in our brand and is in our language since the last 7 years. So we launched this living lab in an autistic school in Montreal called Giant Step, and realized a real world evidence trial, which ended up having additional endpoints as far as algorithms for arousal, for example, for prevention of crisis or meltdowns. But also we came up with an interesting discovery about neurological and emotional imprinting. This is quite complex. I'm not going to go through the details, but this is really where we became expert at. Today, as I mentioned, and just one word I would like to say is we're not just working with children, we're also working with adults. So we work with that German company that has subsidiaries in Canada and the US called Auticon. So the last portion of our story was coming from March 2020, where we've been asked to do that COVID-19 investigational testing at 2 different hospitals in Quebec. And basically, we're testing those innovative sensors. I'm actually wearing my wearable right now. This is the Hopchild wearable. It's real. It's manufactured, it's fabricated specifically for COVID-19, which has also particularities for autism. So our endpoints right now are, some are surrogate, some are direct. Respiratory infection is what we're looking for, and also very much cognitive impairment. So really, what we've developed for autism with autistic scientists and researcher will help us come up with very interesting results for COVID-19 in those two different hospitals in Quebec. That's my 5 minutes.
Well, yeah, that was fantastic, Marc, and congratulations on you know, your journey and your impact, and good luck with the progress here on out. DHIT is here to support you as well. Keep us posted. This concludes our panel. Panelists, thank you so much for joining us today. You were insightful, phenomenal, and yes, painted some real challenges, but also packaged it in an optimistic outlook. So thank you for carrying on the theme. Our next panel is going to be in 2 weeks, November 20th. We're going to be focused on precision medicine. Later, middle of next week, we will get out who our panelists will be. Stay tuned for more information. And again, thanks to the government of Quebec and the University of Montreal Health System for their support. Great partners, and on behalf of DHIT, the Digital Health Institute for Transformation, and the DHIT Frequency, we're tuning out. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye-bye.